Hey, good evening, everyone. My name is Brian Hurdle. I am a clinical pharmacist too, ambulatory care services or ambulatory care pharmacist at the University of Maryland Medical Center, Midtown campus. I'm located in Baltimore, Maryland. Today, we're going to go over the third of three in the NPhA research series, research seminar series. So, some research methods, design, data analysis, workshop. So, my intent for this particular discussion is to just go over a few of the, well, very, very high level, because if you guys already know, statistics is extremely deep, but just some of the overview for a lot of the things that are pertinent to putting a poster presentation together. So this is my entire intent, was to help those who might have been on the fence about doing some research or putting a poster together, to kind of nudge them towards the direction of putting their research out there. A lot of us have great ideas, and we have research questions. There's things that we notice, or things that we have done at our, schools, community practices, pharmacies, so on and so forth, that I feel, our community of pharmacists and the nation really should know. So, anything that I can do to encourage you to, get your stuff out there, I'm hoping that this will be, get you started. So, in order to do so, I am going to, once I advance the slide, there we go, and view some of those important statistics concepts. So this might be a refresher for some if there are any students that are here. Hopefully this will be a nice review for the NAPLEX, because like it or not, there are going to be statistics, epidemiology questions that pop up on the NAPLEX. Some tests, it's all random, might have more than others. I knew someone who did extremely well on all of the different sections of the NAPLEX except for the statistical concepts, and that actually caused them to get a failing grade. So it wasn't any fair that, they were randomized to have a whole lot. Statistics was a weaker subject. They were extremely sharp in everything else, pharmacy related, from drug knowledge, drug interactions, so on and so forth. But statistics and research methods was where their knowledge, wasn't sufficient, and things didn't work out well for them. So I'm hoping that doesn't happen to anyone here who is, finishing up their pharmacy school career, this summer, and like looking to sit for the NAPLEX. So I will also talk about some research methodologies that are useful for poster presentations, and those key components that are very pertinent to putting things together. And then at the end, I'll try to wrap things up in a bow, provide you with a little bit of a blueprint of how to go from A to Z when doing your research. So let's start with the stats review. So statistics, we are always going to be studying variables, variables. We have a lot of information out there that is collected, and or we can collect information and turn that information into certain variables. We get it from our study participants. We get it from our patients. If we're doing that type of study, we get it from data that may have been collected through survey data. So, like in the second session of this our seminar series, I talked about publicly available data. So there's data that is lying out there where you can just get it and analyze, and be able to present, as long as you do not misrepresent the data. It's absolutely free. So if you have some time, I understand that second seminar series video is on YouTube. So I urge you all to take a look at it if you haven't. So there's two major types of variables. We have our exposure, or our independent variable, and our outcome variable, or our dependent variable. So the independent variable is what is typically going to change and then make changes to the outcomes. For instance, our independent variable, if you're trying to see if cigarette smoking is, strongly associated with lung cancer, we would look at patients who have reported smoking for a period of time and see if they have lung cancer, and then look at the rates of lung cancer in those people who haven't smoked. Ethically, we won't be able to just give people cigarettes and follow them around for years to see if they are smoking. So that's one of those things that we do with survey data. but we'll get into that study design stuff in a little bit. So our outcome variable is also known as dependent variable. You see several studies, those very large, especially randomized control trials, they might have several outcomes. They might have a primary, secondary, they might call them primary endpoints or secondary endpoints. It's all one and the same. So you're going to have our variables. We have our study population. We have what we're looking at, and then we have things from start to finish, our exposure, and then we have what the exposure is actually working on, which would be our dependent variable. Within those variables, we can break them up into two major types. So we have both our continuous variables and our categorical variables. Categorical variables are, seemingly just that. We can group these things. They could be things such as gender, such as symbols gender, age, race, ethnicity. Years of college, if we look at them from freshman, sophomore, junior to senior. We have also our special categorical variables that are binary ones. Most of the time, we'll see yes, no, positive and negative, one or two, or something, but there's typically just only two choices in that entire category. Then we have the ordinal variables. Those are somewhat different. If you think of things like if you're at a fast food restaurant and you look at the drink choices, small, medium, and large, that can be an ordinal categorical variable because the small is going to be a certain number of ounces, which is less than the medium, which will be in turn less than the large. So that's how we can put things in a particular order and still have our categories together. More commonly, we see continuous variables. That's where we gather things in number. The easiest one to think of is age. We have weights, even systolic and diastolic blood pressures if we take those separately. There are special types of continuous variables. There's a discrete one that has only whole numbers or there's no decimals or fractions. So oftentimes we look at age that way if we want to just take it without going to the number of months a person has been alive. And we just look at their birth date and when compared to the current date. We can have a ratio numbers, a number of variables that can never be zero. Again, age is another good representation of that. There are people who don't have a zero age. We don't start counting their age at, zero. There might be gestational age, but that's a separate type of variable altogether. Then we have the intervals, positive and negative numbers. So think of your temperatures. You can have a minus 32 degrees. You can have a positive 32 degrees, and I'm talking about Fahrenheit. And it could go up to, whatever number or go down to a certain number. So interval continuous variables have both positive and negative numbers. It's really important to remember the types of data, be it categorical or continuous, because that will determine how you analyze that information once you have the data in front of you. So when we want to put our data together, our categorical variables they're always going to be summarized as a frequency or count. And then they can be expressed in proportions or percentages. So we have a percentage. If we have a room full of students, we can count the number of those born male and the number of those born female, or who refer to themselves as male or female, and then come up with a count, and then also out of the whole come up with proportions or percentages of those two groups. And if we were to look at this graphically, categorical variables are your friends as far as putting things on graphs when you're looking at doing a poster, because they're easily put in bar graphs and bar graphs, bar charts, or pie charts. I was told not too long ago, I probably should have taken pie charts over that. Not many people, recommend using pie charts anymore, and I think their use have kind of fallen out of favor. So it's probably best to stick to bar graphs or bar charts if you want to display categorical data. Now, continuous data, that's summarized by looking at the central tendency, or that's a fancy way of saying we're looking at the mean, median, or the mode. The mode, if you remember, is the number that shows up the most often. You don't see that too many times in scientific research, but it's just another way that you can, express or summarize your continuous data. You will definitely see the mean, median, and also standard deviations for a lot of things that we do in our scientific careers and a lot of things that we read as far as the journal articles are concerned. In order to display this data, we can either do it a histogram, line graph, scatter plot, box plot, which is a box and whisker plot, a density plot, or even a area chart. Most of the time, continuous data is often shown on in a table, and there's a lot of other variables that'll have continuous data, and then you'll have the mean and the standard deviation. Here's an example of what I was talking about. So this is table one. Typically, table one will always show the demographics and clinical characteristics in a research journal article. Now we can see our categorical variables. Let me get my little pointer out. Give me 1 second. It's gonna be green. So here's some of our categories here. Race or ethnic group. This one actually shows that it's going to have the number right next to the percentage. So out of the entire group, we have a total of 2,202 people in the canagliflozin arm of the study. 762 or 34% of this entire group here has reported female. The same thing goes for the race and ethnic group. You can see how many were white or Caucasian, Black, African American, Asian, or other. Then we go down to other things. Now, here's one of our continuous variables, duration of diabetes. How long has this person been treating or managing type 2 diabetes for this particular study? So the average person in this study has been diabetic for 15.5 years, plus or minus 8.7. So they're giving you a bit of a spread or a standard deviation. So you can kind of see the average and then where your pluses and minuses are concerned as your standard deviation is. So it's going to be 8.7 in this instance. Another continuous variable here, body mass index. We have blood pressure. And then we also have the estimated GFR. So you can see the difference in how we are to display categorical and continuous variables when we're doing literature or journal articles, so to speak, or you can do the same thing if in your research posters as well. But you just definitely want to make sure that you're representing the data in the proper way. So look at if you have categories, make sure you always report it. You can do number and percentage. And then if you're doing something continuous, you want to have the mean and then the standard deviation right next to it. All right, so moving on. Okay, well now it's got a lot of things drawn up here. Let me get rid of the drawings. Clear my drawings. All right, there we go. So there are a couple main statistical tests that you would see in a majority of the research. The first one, and probably the most simple, is the t-test. T-test use compare the means of two groups. So if you are giving a drug versus a placebo to a certain number of people and you want to look at the effect, for instance, the number of people whose A1C dropped by 5 points. And if they looked at that for the canagliflozin study, you would compare the number of people, or get the mean of the proportion of people in the treatment group who received the treatment drug to the number of people who did not, and then compare those two. After that, we start to do other tests that I'll talk about in a second in order to interpret that information. Another way to do a t-test is you can start with the same group and have a before and an after type of thing. So sometimes you'll see certain classes, in certain colleges where they'll give you a test on the first day of class. They don't expect you to do well on it. They just want to see your level of knowledge prior to taking the course. At the end of the day, or at the end of the course, they will give you the exact same test to see how people fared. Then they will look to see if there's a difference between the beginning and the end scores. If the teacher is good and the students are understanding what they're saying and seeing and learning, then you would expect the scores at the end to be higher than the ones at the beginning. And that's all done using a t-test or a paired t-test. Now, the analysis of variance, commonly referred to as the ANOVA, is used to compare the means of three or more groups. So it's similar to a t-test, but instead of just having one or two groups or the same group done twice, we would have three or more groups. That's useful if we have very large groups and very large studies. The chi-square test, the chi-square test is going to be the friend of a lot of us doing this type of research, especially things for posters, because we can use to look at the relationship between categorical variables. A lot of things that we do, we can generate categorical variables and be able to analyze them on using a 2x2 table, and then do that data using the chi-square test. So we have our exposure, and then we have our unexposed, and then we have that the person, you know, get the endpoint that we're looking for, and that's just yes or no. So we're just pretty much comparing two different groups of people, yes or no, in those exposed and unexposed. Correlations are typically done when we have two continuous variables. So if we're looking to see if there is a correlation between age and, say, something like BMI, or age and something like blood pressure, we would be able to run a correlation as statistical tests that allow you to put that data in, and then you're looking for the correlation, which is represented in a figure called R, or the Pearson's correlation. When you see the R, then you'll be able to correlate or make an association of the strength of the correlation. R runs between -1 and +1. The closer you are to +1, that is the strongest direct proportional relationship. And the closer you get to -1 is a strong direct negative proportional or inversely proportional relationship. The last one is kind of like one of my favorite. We have a regression analysis. One of the most common ones is logistic regression, where we are looking to see if the variables that we place in our particular model have the impact on a binary variable. So typically it's going to be a yes or no. Multiple logistic regression, you can actually control for certain factors, and those are called confounding variables. That's something I probably should have put in there, and I apologize that I didn't. Confounding variables are those things that kind of muddy or get in the way of the exposure. Somewhere that sits between our independent variable and a dependent variable. So it makes it harder to have a strong association directly from the independent variable to the dependent variable. So for instance, if we're looking at people who say, a popular thing is that a lot of people are using GLP-1s for weight loss. And we want to look at the association of the people who use the GLP-1s, such as Wegovy or Zepbound is the other one approved for weight loss, and the percentage of body weight that they lost. Now, a good study would also include the amount of exercise that a person obtains on a weekly basis, because as indicated, as written, maximum weight loss and weight management can be gained using those medications in concert with both diet and exercise. Now, if we get a group of people who are not very active, but they're just taking the medication to lose weight, then we wouldn't expect to see that much, a great percentage of weight loss. But if we never ask them about their um, exercise practices or the activity levels, we might assume that the medication that we give them does not reduce the weight as we or as advertised. So if you are actually doing that study, it would behoove you to ask about diet, practices, physical activity in order to be able to find a stronger association between the GLP-1s and the percentage of weight lost at the end of your particular study. Now that's just an example, but it can be done in many different ways. And when you're designing your research studies, you definitely want to think about confounding variables or things that can get in the way of a true um, association between your independent and your dependent variables. So I'm gonna pause here for a second to see if there are any questions. Okay, so I'm gonna keep going. All right, so let's talk about probabilities. We're not talking about probabilities, so to speak, as one of those things that you saw probably when you were in elementary or middle school, where you have a bag of marbles and there's five green ones and there's six red ones. What's the probability of pulling out a green marble? No, this type of probability deals with the statistics that we deal with every single time we look at a research study or when we're conducting research. Why is it important? We have two separate categories or two different ways of looking at the probability that you will always see. We have one on the left-hand side, I have alpha. Alpha is typically always a set or fixed value. The gold standard and what is often understood, unless it's expressed in a particular research article or if you decide to do something different, is setting your alpha at 0.05. Why is 0.05 important? If you multiply that by 100 to get your percentage, you get 5%. Now, when we set our alpha here, we are saying to the world that there is a 5% probability that we got these results by chance. Or there's a 5% probability of making a wrong statistical conclusion. So if we have anything that's lower than that alpha of 0.05, then we're saying that this is what our percentage of is that we got the results of our study by happenstance. So the lower number that you get as far as your statistical tests are concerned, the better when it comes to statistical significance. And that's where we go over into our p-value. Our p-value is what we generate from our research. And this will give us the exact probability of if conditions were repeated, what we would see as far as our study is concerned, that we did it, that we obtained these results completely by chance or not. So we want those p's to be less than alpha, and that is what is considered as statistically significant. If p is greater than alpha, we would say our findings are not statistically significant. And there's a lot of things, some people, they're hoping that their research will be statistically significant at the end of the day as we go through our, the painstaking process of doing a study and putting our data together. But that's not always, like the end of the story, because there's something that we also refer to as clinical significance. So statistically, we just talked about the likelihood of something that's happening by something other than mere random chance. The lower the p-value, the lower the probability or percentage that this happened by chance. But clinically, how practically important or meaningful are the results of the study in a real world setting? Depending on the size of our study or depending on our population, we might not be able to achieve statistical significance in our studies, but we might have very, very good clinical significance. And that's something that I really implore everyone to be able to go ahead and be proud about if they find something that is very clinically significant. For example, if you instituted a program at your pharmacy, if you're at an outpatient pharmacy, or even if you're an ambulatory care pharmacy like I am, and you are doing have interventions as a pharmacist in order to lower the blood pressure of the patients that you touch. Now we want to see that whatever you're doing, all the methods and the steps and your interventions are lowering the blood pressure of that population. Now, if you were to do a t-test before and after of the same population, you might not see something statistically significant. But if we are seeing reductions and a certain number of millimeters of mercury in both systolic and or diastolic blood pressure, we would say that is clinically significant. And in certain areas, that is more important than statistical significance. And it's definitely something that you should talk about and share with others. Because there might be something that can be replicated in other hospitals that have a similar population or demographics as yours. And it might even be something that can be modified or tweaked to make it something that can be done on a grander scale. So all of it is extremely important. So don't feel pressed to just find things that are just statistically significant. Clinical significance is extremely important as well. So let's go into some of those research methodologies and the study designs that you will utilize or can utilize in order to get your poster done or even published at the end of the day. So we have quantitative research, qualitative, and mixed methods. There are several more, but these are the most common. Quantitative research, that's when we're looking at the quantity of things, a collection of numerical data. We're identifying patterns, relationships, or trends. So that's done with, your surveys that you typically see all over the place, certain experiments such as randomized control trials, longitudinal studies, and statistical analyses. Our qualitative research is slightly different. It's a little bit more drawn out and it takes a little bit of special type of analysis because we need to understand the phenomena from subjective and a human-centered perspective. Oftentimes, this is done in focus groups or patient interviews where we're not looking for the numerical representation of what they're saying. We're looking for exactly what they're saying and how many times this particular phrase or comment shows up out of everyone in the population. And those are things that we like to put together. Modern ways of doing it now, people put things in certain programs where they would generate a subject or a word cloud, where, the thing that shows up the most or the idea or concept that shows up the most is the one that then pops up largest inside of the cloud. So that is one way you can start to collect that qualitative data. Mixed methods is a combination of both. You can do both, and oftentimes it might be helpful to get an idea of how people feel about certain interventions that you're making without using a Likert scale. You just want to hear their words, testimonies, so to speak. You can get a collection of testimonies and put those together. In addition to having someone fill out surveys with responses that can be on Likert scale. Some of the common study designs, I have about three here. The biggest one that we know about, we hear about all the time. And, when I got into research, this is all I could think about with the experimental study designs, where you have those large randomized control trials and you have people randomized, either treatment or control group, and then you analyze the difference at the end of the day. We see this all the time, especially in our line of work. New drugs come out. There are going to be very, very large RCTs that are in phase 3 of the drug approval and oftentimes in phase 4. So they can kind of get an inference. And then a lot of the ones that we deal with have fancy names. So I'm very much interested in studying anti diabetic medications. So I've looked at a lot of the SGLT2I studies, such as the Cadence study, NPhA, so on and so forth, just to get information from those. So randomized control trials are everywhere, and they do take a lot of time. So that is one of their weaknesses. Another big weakness is that it might not be representative of the total population because the people who are part of the study they have to volunteer for that study. So oftentimes, if I were to go back to what I showed you a few minutes ago, or if you remember, the proportion of the patients in that study for the canagliflozin arm that were white was significantly greater than all the other races and ethnicities in that study. And oftentimes, that's one of the weaknesses for a randomized controlled trial because depending on where they conduct the trial, it may not be representative of the global population. One of the biggest strengths is that you can establish a cause and effect relationship using a randomized controlled trial. So we know, or we can say, based on the statistics, that giving a person this particular medication caused this outcome. They are strictly controlled. There are many randomized controlled trials where people are administered the medication by study people who conduct the study. They have doctors, nurses, maybe even pharmacists that will administer the medications just so things are done in a controlled condition. As we know, this is not real life. If a patient comes every single week to get their medication at the same time every single week, in the real world, there'll be times where people will forget, or times where people can't do it at the same time, or if something would happen to the person where they may be, away, forget their meds, discharged. I mean, to be in the hospital and haven't been discharged, so on and so forth. But these are things that we do consider when we're doing that. One of the things that we can do as a researcher and as students, and even those if there's residency, I think someone's there's PGY1 residents, you can do quasi-experimental designs. It's similar to RCTs, but they lack the random assignment. Oftentimes, quasi-experimental ones can be conducted just by looking at electronic health records that we have available to us. And most of the times, those large or even small hospitals will have some level of data that can be um, obtained for us through our informatics team. The next study design I'm going to talk through is observational studies. Now, this is one that is probably I would say, is the easiest one to actually pull off. So we're just looking at the variables and we don't manipulate the variables. So we're looking at the data that's already there. I talked about, where to find free data last seminar. So this was a week ago. So that is a way to do observational studies. You can do a cohort style study where we're following a group of people over time. You can do a case control where we have the individuals who have the cases and we compare those to the people who don't have the cases and then look back to see exactly where they received this exposure or if they were exposed to the independent variable in question. Then we have a cross-sectional data. Cross sections can be from a month, a week, usually about a year or two, where we want to identify the prevalence and try to make correlations in our independent variable and our dependent variable. So one of the strengths is that we can't manipulate those. So there's really no ethical concerns there. We don't have to worry about giving someone, a particular disease in order to see if they are exposed them to a particular pathogen to see if they develop a particular disease. We already know that this person has been exposed, and we want to see if they develop it or not. So it's really easy to generate hypotheses using observational studies. And if we were to, try to start to get into some research, come up with some research questions, I would say this probably be the best place to start. One of the weaknesses, and then, it's the way you definitely have to be worded in your poster is that you cannot say anything from an observational study standpoint that one independent variable directly caused the what we see in our dependent variable. We can say there is either a strong or weak association or a strong or weak correlation between our independent variable and our dependent variable. So it's just one of those things to explain, but most of the time, the people who are coming to look at your posters, to read your research or anything, they understand that as soon as you say, okay, I have a cohort study, this is my case control study, that, they're not looking to see causality because it's something that just can't be um, outlined with this type of study. Okay, the last one is a systematic and review or meta-analysis. Now, these synthesize existing research. So we're looking at a collection of research that's already done to provide a comprehensive overview. So we come up with our hypothesis, and then we want to go out there and look at all the research that has been done on this particular topic to see if statistically it fits our hypothesis or if it explains our hypothesis. So the strengths, there can be a high level of evidence that can identify pattern and certain gaps in research. One of the weaknesses, the biggest one that I can think of is extremely time consuming. And another one is that there may be a hard time finding really, really high quality data. That's one of the things that you have to go through when you're doing a systematic review or meta-analysis. Now, the best systematic reviews and meta-analysis, you'll actually have to register your entire methodology and protocol to a particular organization, and that gets reviewed. And that's adds a little bit of validity and to your research. But again, it takes a little bit of time to put all that together. And then depending on what you're researching, there could be thousands of journal articles that you would have to go through and eliminate the ones that don't fit what you're trying to do. So coming up with really good inclusion and exclusion criteria takes a whole lot of time. So how do we put everything that we talked about today and in the past few weeks together? So you're ready, and I hope you're all ready to do some research. So first, you want to start with creating your research question and your hypothesis based on your interests, where you are in school, or if you're working at a pharmacy, part-time, or if you're a resident, etc. You want to come up with something that is interesting to you, something that is also attainable, something that you can't do without grinding your gears. Things will be right in front of you. You'll have a lot of people who can help you. So that brings us to my second point. You want to investigate the resources that you have around you. What is your study population? Where are you located in the country or in the world? What databases do you have available to you? Or if you have an electronic health record, is it easy to, once you come up with your study design, your hypothesis, and is it easy to actually get that data from your electronic health records through your either informatics team, or is it something that you can do on your own? And then finding statistical software to be able to analyze that data. So last week I talked about some of the options. Some organizations will have either SPSS or Stata or even SAS to be able to go through the data. If not, hopefully we're connected to some other organizations where we're able to do that, and we won't have to pay for it out of pocket. So getting, with those organizations or health systems or even our schools, colleges, universities, that data information software is more than likely out there for you. You just have to know whom to ask to be able to obtain it. So again, so that whom to ask comes to my third point. Talk to your colleagues, your advisors, your faculty, your preceptors about your ideas. I know, like I was a resident, and I have residents here, and I hope a lot of you are looking forward to either residency or fellowship. You're going to have to talk to someone to see how to get this thing off the ground. They typically, you most likely will not be the first resident, and you most likely will not be the last. So a lot of times there are systems that are already in place. And hopefully you'll have someone that you can connect with that'll be able to give you a hand or be willing to, be a contributing author to your poster or your journal article. The next part, the next two, I would say both are the fun part. I put that for number five. But you want to design, find a study methodology that fits the resources that are available to you. If all you have available to you are electronic health records, you're definitely going to be looking at an observational type of study. So then you want to see, okay, am I looking at a cross-sectional study, or am I going to do a cohort or a case control study? All of those things will be available to you, and then asking certain questions or looking at certain metrics you'll be able to come up with those right away. And then conduct and analyze your study. This is the fun part. It's a lot of hard work, but I say it's fun because at the end of the day, you'll get something that you will be proud of and something that you can definitely want to display. And if it's something that you weren't looking for that was uncovered, that's even better. Finding something that wasn't looked for that just pops up out at you is definitely another notch in your belt, and it might even lead to further research down the line. Then it comes the interpretation. If you're good at analysis, if you're not, work with your advisory faculty and preceptors. What do your results mean? Why are they important? Are they clinically or statistically significant? If they're clinically significant, that is extremely great. That's definitely something we at NPhA want to see because it would help us, especially if you have on working with certain populations, especially underserved populations. We want to see that information. We want to be able to take it back to our respective organizations and share that or be able to implement it at our own practices. And then disseminate. Poster presentations. We have our poster presentation come up at the annual conference. I just want to say, once again, the deadline for abstract submissions is May 1st. So those of you who are doing research now, there are still some time to be able to get that in. And then conference presentations, once you are practicing, or if you have that research where you're with your advisor, you might even be asked to join a panel, a roundtable, or be out there to have your own presentation. Again, residents, they have their own presentation at their own conferences. If you're in the Northeast, you most likely be going to the Eastern States Conference, but I understand just about every region of the country has something similar to that. Or they may even have you go down to APHA or ESHP and present your poster, or you might even have a research section where a session where you'll be discussing your research for about 12 to 15 minutes. So my final thoughts after going through these three seminars, I would say conducting research can be fun and completely rewarding. It should be rewarding for you, and then those who are able to glean some information or some knowledge from your research, it's rewarding for them as well. If there's something that could come out of it that will impact the lives of more people, that is definitely what we are looking for. So don't be afraid to get into it. There are many resources available. You just have to ask. Just need to know where to look. I myself, hopefully, you will consider me as one of your resources because I will be very happy to help you along your journey as far as getting from A to B in research, as far as your poster is concerned, or if you have any other questions about anything pharmacy related, I'd be happy to talk to you. So, like I mentioned before, our community, we need fresh faces, fresh ideas, and a different look at the populations and in which we serve. So on NPhA, would like to thank you, and I like to thank you all for coming out tonight and spending time with me talking about research because it's one of the things that I love to do. I like to dig into data and analyze it every chance I get. And every stop I've had in my pharmacy career, I found ways to pull data or analyze data, whether electronic health records or helping my department chairs, directors pull data for the stakeholders at the higher level or those in the E-suite. So before I go, there are a couple of things coming up. Let me get the NPhA calendar up. And while I do that, do I have any questions from anywhere out there? Thank you for joining me again. All right, so let me switch over to displaying the coming events. Oops, I'm doing that the wrong way. So, all right, so if anyone is going to be at APHA 2025 this weekend, there's a networking reception that they're having at the Omni Nashville Hotel. Um, is let's see, let's click on it, see if is registration still open because I know it fills up fast. Okay, it looks like the registration is still open. So if you're going to be there and you like to network with like-minded pharmacists as yourself, please, please, please register. We'd love to have you down there. Okay, next, also on the 25th, there's a a session called Resilience and Landing a Full-Time Role. So that is very, very extremely important. It does take a bit of work, and I'm sure that the panelists there will be able to give you a lot of insight for those who are coming out of residency, or even if you're coming out of a fellowship, or if you're trying to go straight from being a student pharmacist to a licensed practicing pharmacist. We had a legislative briefing congressional fly-in down here in Alexandria, Virginia on March 31st. And then I want you to remember that we have the 2025 convention August 1st. Registration is open now. There are discounted rates for early birds, and then also student rate is lower for our SNAFA members. Again, I implore you all to if you, I really, really would love to see as many of you out there with your posters at our poster presentation. And again, so I will go to the annual convention page and I'll show you exactly where you can register for that. So down here, the deadline is May 1st. All the abstract guidelines are here, and this abstract submission is down there as well. But all right, so are there any questions? I'm so happy to see so many of you out here tonight. All right. Well, thank you all for dropping in. Thank you for your time. Again, my name is Brian Hurdle. I will put my email in the chat if you would like to contact me about anything research related or NPhA related, or if you just want to just say hi, I'd welcome you to it. And I wish you all have a very, very good weekend. And I do hope to see each and every one of you at the annual convention in Cincinnati, Ohio this coming August. All right. Thanks, everyone.